If you're a clinician, you are busy. And if you're revising for your MSRA, you're probably thinking the ethics of medical research. Well, that's a problem for the chief investigator, right? The big academic names.
Exactly. The PhD students, maybe.
But the latest guidance from the General Medical Council, the GMC, is saying actually, no, it's for you. Our mission today is a deep dive into the GMC's updated Good Practice in Research standards. We're going to turn these dense professional rules into high-yield, actionable knowledge for your clinical practice and, crucially, for the SJT.
And it's so important to get the scope right from the start. This guide builds directly on the core of good medical practice. It's all about what's expected of you as a doctor when you're supporting or carrying out any kind of research.
So that's everything from big drug trials to, what, records-based studies?
Yep, anything involving people, human tissue, or patient records. The goal is simple. Make sure research helps future patients, but never ever at the expense of the person right in front of you.
Okay, so before we get into the weeds, what is this not about? Because that's a common point of confusion.
A really key distinction. This guidance does not cover your standard clinical audit. So, measuring current practice against a known standard.
Like checking if patients got their aspirin on admission.
Exactly. It also excludes service evaluation, so asking for feedback on a new clinic process, for instance. And it doesn't cover giving a patient a novel treatment just for their own specific clinical need. That's innovative care, not research.
Got it. So the moment your goal shifts from checking your own service to creating knowledge that can be generalized and published.
That's it. That's when you step into the GMC's research framework and all these rules kick in.
Okay, let's unpack that first section then. What does the GMC expect from all of us, even if our name isn't on the grant application? It seems to focus on promoting participation.
It does, and this is a massive area for the SJT. The core idea is that research is a universal professional duty.
But it's not just about agreeing. Research is a good thing. The guidance is specific, isn't it? It talks about underrepresented groups.
It's very specific. It explicitly names women, children, older people, ethnic minorities, and people with disabilities. Because if these groups aren't in the trials, the evidence we generate just isn't as good or as relevant.
So what's the actionable duty here? What do you actually have to do?
Okay, 3 things. First, you need to actively support research. That means telling patients about relevant opportunities if you know of them, signposting them to the research team.
Not pressuring them, just informing them.
Precisely. Second, and this is a big one for bias, you have to avoid making assumptions about who might be interested or who's eligible. You offer the opportunity fairly.
And I guess third is to proactively encourage those underrepresented groups to take part.
That's the one. And this all comes with a huge integrity check. If you're discussing participation, you have to be totally open and honest about any interest you might have, financial, commercial, whatever.
So if the study is sponsored by a company you've done some consulting for,
You have to say so. Your advice has to be seen as being purely in the patient's best interest. And it goes beyond just patients. You also have a duty to help create a research-supportive workplace.
what does that mean in practice?
It means sharing information, helping to identify areas for study, and supporting your colleagues to get involved in research, especially colleagues from those same underrepresented groups. It's about building a culture.
Okay, so that's the baseline for everyone. Now, let's raise the stakes. Section 2, this is when you're actually involved in carrying out the research. The bar for safety and ethics gets exceptionally high here, doesn't it?
It's the absolute highest priority. The core principle is non-negotiable. The interests of the participant must always come first. That's straight from Domain 4 of Good Medical Practice.
And it all starts with consent, right?
Absolutely. You have to be satisfied that you have proper informed consent before anyone is involved. This links directly to all the detailed GMC guidance on decision-making.
So beyond the usual risks and benefits, what are the must-haves for consent in a research context?
2 things are vital. First, the person must understand their absolute right to say no or to pull out at any time for any reason.
And critically.
Critically, they need an explicit guarantee that walking away will not harm their relationship with their usual doctor or their normal care in any way.
So they can't feel like they're letting you down or that they'll get worse treatment if they leave the trial.
Never. And on the safety side of things, you have to be satisfied that the study design minimizes all the foreseeable risks and that the potential benefits for patients in the future outweigh those risks.
Which brings us to a really practical point about continuity of care.
Yes. You should always seek the participant's consent to inform their GP. It's a huge risk if the left hand doesn't know what the right is doing. If their GP doesn't know they're in a trial for a new cardiac drug, things can go wrong very quickly.
And now, for what I think is the real aha moment in this guidance, especially for anyone revising for their SJT, the duty to stop.
This is probably the most powerful standard in the whole document. If the results, even early data, show that participants are at risk of significant harm, or that the intervention just isn't working, that there's no patient benefit to be expected, the research must be stopped.
And that sounds simple, but the pressure from funders, from sponsors, that must be immense.
It is. This is the ultimate test of your professional integrity. The GMC is clear. If you can't stop the trial yourself, you have an immediate duty to inform the person who can, the chief investigator, the sponsor, the ethics committee.
So the individual patient safety right now trumps everything else.
It trumps the research goals, it trumps the funding, it trumps career progression, everything. Patient safety is paramount. That's always the highest scoring answer.
So if safety is the guiding star, governance is the scaffolding that holds it all up.
Yeah.
Let's talk about the operational side. How does the GMC make sure the process itself has integrity?
Well, it all sits within a really robust framework. Any research has to follow national laws, the UK Policy Framework for Health and Social Care Research, and it needs approval from a Research Ethics Committee, a REC.
And sometimes the MHRA as well.
Yes, if you're dealing with medicines or medical devices. And beyond the paperwork, it's about competence. You have to have the right skills, keep them up to date, and make sure your team is properly trained and supported.
There's also a newer point in there about involving patients in the design, isn't there?
There is, and it's a great step forward. Design proposals should now consider the perspective of people with lived experience of the condition you're studying. It just makes the research better and more relevant.
Now, a huge SJT topic, conflicts of interest. The stakes can be incredibly high. How does the GMC expect you to navigate that?
The guidance is strict here because this is all about public trust. You have to be completely open and honest about any financial, commercial, or even non-commercial interests.
And the rule is?
If you have a conflict, you declare it as soon as possible. But the key part is this. If you're unsure if something counts as a conflict, you must act as though it is one and get advice.
So err on the side of caution. Always.
Always. And you absolutely cannot let any conflict affect your judgment. Imagine you're consulting for a health tech company whose AI tool is being tested in your hospital. That's a clear conflict you must declare and manage.
Okay, finally, let's talk about reporting. It's not enough to run a good trial. You have to report it honestly.
Absolutely. The data belongs to the scientific community and to the public. You have to keep accurate records, obviously. But the core ethical duty is to report all your results accurately and objectively.
And that includes the bad news.
Especially the bad news. You have an explicit duty to publish adverse findings or negative results, usually in peer-reviewed journals. You can't just bury the studies that didn't work or that were commercially, inconvenient. That's scientific misconduct.
So let's bring this all together for you, the listener. What this guidance really does is embed research right into the heart of everyday good medical practice. It's not some optional extra.
Not at all.
We've covered a lot, but I think there are 3 key takeaways for your practice and your exams. First, research is a universal duty. All doctors have to promote participation, especially for underrepresented groups.
And support a research-positive culture in your workplace.
Second, participant safety and autonomy are king. They always override the interests of the study. And that includes that high-stakes duty to stop a trial if you see evidence of harm.
That's your non-negotiable.
And third, integrity. That means being proactive about declaring conflicts of interest. When in doubt, declare, and being completely transparent in reporting all of your results, good or bad.
Which leaves us with a final provocative thought, really. One for you to mull over. We know research is about creating general knowledge for the future, but your primary loyalty as a doctor is always to the individual patient in front of you today. So when the huge commercial pressure to get a positive result meets your ethical duty to publish adverse findings that could cost a sponsor millions, how prepared are you, really, to escalate that? To stand up and protect both that one patient and the trust of all patients to come?
A crucial question and a fantastic exploration of a dense topic. If you're looking to dive deeper, we've linked the full GMC guidance in the show notes. And if you're deep in MSRA prep, check out resources like passthemsra.com for more practice on these kinds of ethical scenarios.